Ayush, you rightly pointed out there is a lot of noise. So as long as there is noise, we can wait for things to become clear. Sure. I'll be, after listening to all the presentations on cross-linking, the topo-guided PRK, the Aurora Intacs and stromal segments, we move on to DALK for keratoconus. I have no financial interest. I'll shorten my talk as well. Now, it's a general consensus that once you are not able to fit contact lenses, whether it's the rose scale lenses or the scleral lenses, and the patient is not able to tolerate, then you look at surgical options of restoring the corneal shape. Now, deep anterior lamellar keratoplasty refers to a surgical technique wherein you retain the healthy host endothelium and replace the pathological stroma with healthy donor tissue. The advantage is that you avoid endothelial rejection, so you get long-term survival of the graft, and because you don't use steroids for a long time, complications associated with steroids like glaucoma and cataract can be avoided. There are two main techniques, one where we try to expose the pre-decimus layer, and the other one where you do the near decimus dissection. Exposure of the pre-decimus layer can be done by injection of air or viscoelastic, and the near decimus dissection you do layer by layer dissection. Preoperatively, you need to have some idea of the extent of the pathology, the regional pachymetry, and on anterior segment OCT, you see whether the pathology is involving the decimus membrane or is there any scarring of the pre-decimus layer. The big bubble technique was described by Mohammed Anwar back in 2001, and here you are using a 27 gauge needle to inject air into the stroma that creates a separation between the stroma and the pre-decimus layer. Earlier we thought it was the decimus membrane, and this, with the needle, it gives a success rate of about 65%. A type 1 bubble is when you get the bubble starts in the center, has a dense white frothy margin, and the separation is between the stroma and the pre-decimus layer. Type 2 bubble has a clear margin. It's a separation between the pre-decimus layer and the decimus membrane, and it can extend all the way to the limbus. Now you need a guarded depth trefination, for which you can use a Hesburgh-Barron trefine, or you can use a handheld guarded depth trefine measuring 300-350 millimeters microns, or you can use the femtosecond laser, which gives you a shaped cut, so you can use a mushroom or you can use a zigzag. And in very large areas of ectasia, sometimes you may have to use a preset depth guarded diamond knife to make the groove. I prefer to do a debulking, after which I inject my air. Debulking helps deeper placement of the cannula, and once the bubble forms, it leads to faster deflation rather than spending time to debulk at that point of time. However, if the apex is very thin, you don't debulk the apex because then the air starts coming out anteriorly. Instead of the needle, there is a wide array of cannulas which are available, which are blunt tipped and have bottom port. They assist in formation of the big bubble much more easily. Now if you see here, after we have done the trefination and debulk, the air injection cannula is introduced, and as you inject air, you see the formation of the type 1 bubble. You can see it has a dense white frothy margin. As you inject air, it expands, reaching up to the margin of your trefination. You can do a sequential injection, whereas you initiate the bubble and then you do a paracentesis and then do the second injection. This is fairly repeatable once you are able to introduce the cannula up to the right plane. And if you select your cases where there is no abnormality affecting the pre-decimus layer, chances of complications are much less. In this case, you will see that we are using a viscoelastic to introduce what is called the visco bubble. So it works pretty much like the air, but here you use cohesive viscoelastic, and as you inject the viscoelastic, the air bubble in the anterior chamber gets displaced to the periphery. If you have an apical scar like this, where injecting air can lead to undesirable effect, we do the partial thickness trefination, debulk. After we have debulked, we come to the periphery, make a peripheral pocket. This pocket is carried along the margin of the trefination. So this is basically a modification of Malbrand's peeling technique. So once you have done that dissection up to 85 to 90% depth, your left hand you have a tooth forceps, and as you try to peel the stroma tissue away, the right hand you can have a blunt dissector just separating the fibers as they are separating. When you come to the thin apex, you have to be a little careful for the amount of pressure that you are applying, because if there is a pre-existing break like in hydrops, you can end up splitting the cornea at that point of time. This is a manual DALK. You can see that there is a very thin residual bed. So if your residual bed is less than 80 microns, you can get results which are as good as the big bubble technique. If you have access to intra-op OCT, you can use the OCT in real time to see the amount of residual left behind, and you can use that to plan your surgery, and even for the cannula placement, you can see what depth the cannula is placed. Post-operatively, one of the common complications that can happen, especially if you have had a microperforation, is a double anterior chamber. So intra-op, if you do get a perforation and you intend leaving an air bubble inside the anterior chamber, do perform an inferior surgical PI to prevent a pupillary block or a Ehlers-Danlos syndrome. In case you have perforation which involve the inferior quadrant, instead of air, you can use 20% SF6 for longer tamponade. So post-operatively, the eyes do very well. You can see good cell counts, which because the healthy host endothelium is retained. You don't use steroids for a pretty long period of time. Usually over a period of 4 to 6 months from full-strength steroids, we move on to softer steroid. Suture removal can be initiated. The interrupted sutures, you can start between 3 to 4 months. You can remove some sutures to manage the astigmatism. But the remaining sutures, we try to keep them as long as possible, at least for 1.5 to 2 years, unless they break earlier or they become loose. Femtosecond laser has an advantage that because of the better graft-host junction apposition, you can get good refractive outcomes. However, once all the sutures are removed, because the host cornea has inherent keratoconus, sometimes you can still end up with unpredictable astigmatism. Comparative study between decimatic and pre-decimatic, they have found that the visual outcomes are comparable, especially if you look at outcomes beyond 6 months. And so a lot of surgeons are saying, do you really need to inject air? They are going ahead and doing a manual DALK in most of their cases, going near decimus, trying to leave behind a very uniform interface and a residual bed of less than 80 microns. So in conclusion, DALK should be the procedure of choice for corneal transplant in keratoconus. Don't go back and do a penetrating keratoplasty. Surgical techniques are continuing to evolve to ensure more predictable outcomes, and the use of femtosecond laser technology and the intra-op OCT can definitely help improve outcomes in future. But even in your outpatient department, if a patient comes demanding DALK, saying that, I get that in my OPD, people come and say, I have keratoconus, I want DALK. I ask them, have you had a contact lens trial? They said, no. I said, then you first need to have a contact lens trial, because if you haven't used a contact lens, you don't even know what a contact lens can do for you. So a surgical intervention is always the last initiative. Just one point to make about topo-guided PRK, I was a good fan. I used to do them a lot, but I'm slowly moving away from any tissue removal procedures. I would rather look at tissue additive procedure. That means I would do stromal segments or put in segments where I can normalize the curvature better without sacrificing. Because I've burnt my fingers, Nitin has results showing 1.5, 2 years follow-up. I've seen these patients 4, 5 years down the lane, 7 years down the lane. They all go in for progressive hyperopia. They become +1, +2, and then the cornea starts becoming more flatter. I think it is because when you do cross-linking, sometimes the regenerative capacity of collagen is lost. So that's why you see this abnormal flattening, progressive flattening that you see. Since you cannot predict in a young patient who may otherwise not be very symptomatic, at least you would not want to do something for which you don't have a solution later on when he comes with the complication. Thank you for your patience here.